Thank you for joining us for the Parenting at Mealtime and Playtime webinar. The Ohio chapter of the American Academy of Pediatrics operates this program with the financial support of the Ohio Department of Health. The Parenting at Mealtime and Playtime program, also known as PMP, has continued to evolve over the past several years to offer the best possible resources to you and the families you serve. Today, we are excited to share more information on tips for working with families. In this webinar, you'll be hearing from 3 experts in obesity prevention, child nutrition, and prenatal interaction. We're excited to share the information from Dr. Chris Bowling, a pediatrician from Cincinnati and the current chair of the section on obesity with the American Academy of Pediatrics. Dr. Bowling will discuss how to motivate your clients and families towards positive change with sensitivity and compassion. Dr. Amric Khalsa is a primary care pediatrician and researcher from Nationwide Children's Hospital in Columbus, Ohio. Dr. Khalsa is an expert on child feeding strategies and how parental influences impact a child's feeding patterns. And finally, Dr. Robert Murray, a pediatrician from Columbus, Ohio and the past president to the Ohio chapter American Academy of Pediatrics, will describe the importance of routine and how you can assist families in developing mealtime structure. The Parenting at Mealtime and Playtime program is here to assist you in your discussions with families. We aim to provide tools that will make your interactions more meaningful in the limited time that you have with them and to contribute to positive, helpful behavior change. Now, we will take a look at some of the resources that may be helpful in working with families. In order to access our resources, we recommend that you visit our Ohio AAP website. This is the easiest way to access PMP materials. This is available for all public health professionals at no cost and no login is required. When you visit the website www.ohio.aap.org/PMP resources and click the box that best suits your role. If you're a community health worker that works with the care coordination system, you will find our handouts within the CCS as well. You may find that in discussing behavior change, the readiness ruler is helpful. This will help you determine how important a particular behavior is to a caregiver and their level of confidence to making that change. You can then ask questions around the responses to the questions above, such as, why did you select this number? Or what would make you more confident in making this behavior change? The number they select is a starting point to a more in-depth conversation around behavior change. Our vast array of handouts will help you in sharing information on healthy behaviors, like reducing sugar-sweetened beverage consumption or getting adequate amounts of physical activity. By reviewing the handouts on our website, you can identify those handouts that are topic-specific and relevant to your unique conversation within the appropriate age group for children you are working with. One handout discusses the importance of routine and how families can create a positive mealtime routine. Our handout, Making Mealtime Stress-Free, will assist you in sharing important messages of family meals, putting screens away during mealtime and aiming to have consistent mealtimes each day. Another handout that can help in creating structure is the Meal Planning Handout. This handout offers examples for mealtime planning and ideas for grocery shopping to purchase those food items with budget-friendly tips. Our mobile app has other resources that may be helpful for you or your clients. This mobile app is free for download from the Google App Store. When searching for the apps, search for Parenting at Mealtime and Playtime, rather than PMP, to be sure to find the correct mobile app. To sign up for an account for the app, please follow the instructions here. You will create an account in order to receive helpful reminders and messages for you and your baby. We welcome our first speaker, Dr. Chris Bowling, to present on how we can motivate families towards positive behavior change. Let's get started.
Hello, my name is Chris Bowling. I'm a pediatrician in Greater Cincinnati, and I'm here to speak with you today about using motivational interviewing in your practice to help you with parents of young children and promotion of healthy behaviors. As I said, my name is Chris Bowling. I'm a general pediatrician in Greater Cincinnati. I'm actually in the Northern Kentucky suburbs, and that makes me active in both the Ohio AAP and the Kentucky AAP, and I also hold offices in the National AAP. I'm a volunteer professor of pediatrics at the University of Cincinnati College of Medicine, and I have nothing to disclose for today's presentation. Our objectives today are to learn a few things about motivational interviewing. Essentially, we'll want you to learn the 4 fundamental processes of motivational interviewing, and we'll refer to it as MI frequently throughout this presentation. Explain when to use MI with parents and when to use it with patients. And by the end, we hope that you'll be able to perform 2 motivational interviewing-based tools that you'll learn today. So when we talk about behavior change, what really is the central issue here? It's really ambivalence, or the balance of change. Ambivalence, when we as medical providers and healthcare workers encounter ambivalence to change, we sometimes think it is a client or patient resisting our suggestions, when really what ambivalence is a natural human tendency. If I tell you to go right, your natural tendency is to think, well, what happens if I go left? You're not really fighting against what the person just told you. You're just naturally questioning it. It's a normal human tendency, and it's something that we, as medical providers and healthcare workers, tend to overinterpret in our patients and clients. It's just a natural human tendency to occur. Motivational interviewing actually is a way of addressing ambivalence. It's a way of thinking about how we might help our patients and clients bring about positive behavior change. There are several characteristics to motivational interviewing that are very important to consider. Number one, motivational interviewing is about change. It's not really about just talking with your families. You have a bit of an agenda. You want them to be healthier. You want them to enact better, more positive behaviors. So it really is about behavior change. Along the same lines, there's also a purpose. You really are trying to bring about a change that you've identified with their help in making positive behavior change and improving health. However, motivational interviewing is also collaborative. This is not done in a vacuum, and it's done actually as a cooperation between both you and the person you're talking with. In that same regard, motivational interviewing honors autonomy. We recognize that the ultimate decision to change behavior lies with the patient or client. It's not up to the therapist, physician, healthcare worker, home visiting nurse. It's not their problem. It's the issue for the client or patient, and it's their ultimate decision whether or not to bring about change. Motivational interviewing is also considered to be evocative, meaning that the basis for change and the reason for change resides inside the patient or client. It's up to us to evoke that desire to change within them. Motivational interviewing also uses specific skills, and we're going to go over some of those today. Hopefully, you'll become a little bit more at ease with trying these with the people you encounter. In addition to having a purpose, motivational interviewing is also goal-oriented, meaning that we have very specific goals when we're trying to use motivational interviewing. Concrete, SMART goals that are specific, measurable, actionable, and time-bounded. So they're very specific, although they still are very collaborative. Motivational interviewing also responds to parts of speech. This is the piece of MI that I find rather satisfying because it allows you to use a patient's speech or a client's speech to help you get clues on what might help them through a behavior change. And furthermore, motivational interviewing, we say, responds to both change talk and resistance or sustain talk, which is probably an even better way of describing resistance. In motivational interviewing, we can think about it as having four fundamental processes. The first process is engaging, meaning you have to take time with your patient or client to understand them. You get a chance to make small talk, to listen to what their values are, to maybe ask some pertinent questions, but it takes time. You have to form a relationship with a family or a patient or client. You're not going to be able to counsel about behavior change if you don't know them or they don't buy into the fact that you are there to help them. The second fundamental process in MI is guiding. And this is where you, in a very collaborative way, decide on what's important for the family. You're helping them figure out what works for them, what their priorities are, and what behavior changes might be achievable for them. Again, you're guiding them, you're not deciding for them. As I mentioned earlier, motivational interviewing is all about evocation, and that's why we say the third fundamental process in motivational interviewing is evoking, figuring out what you can say or do that allows them to release their internal motivation to affect a behavior change. It's very targeted, it's very guided, but it takes understanding what motivates them, and it also takes making a plan on where you're headed before you can really do the evoking. But it's a very important piece of motivational interviewing to understand that your role is to evoke their internal motivation, not to impose it from the outside. The fourth fundamental process in motivational interviewing is planning. You consolidate commitment, you negotiate a change plan. But the important thing to remember is that this is the fourth fundamental process. It remains collaborative and it has to follow the other three fundamental processes. We often tend to say, here's your plan, here's the problem, and now follow it. That really is not in the spirit of motivational interviewing. You can't jump to the fourth step without first engaging, guiding, and evoking. Otherwise, you're probably not going to have much success in bringing about a behavior change. So taking the time through the first three steps before you enter the fourth phase, which is planning, and even though it is a planning phase and you're providing a lot of support and guidance potentially, it really remains a very collaborative process. So if we came up with a pragmatic practitioner's definition, really, why should we use motivational interviewing? We can say it succinctly in the following way. Motivational interviewing is a person-centered counseling method for addressing the common problem of ambivalence about behavior change. So when we talk about motivational interviewing, and you're like me, someone who works with a lot of families and kids, is this a technique really for parents or for the children? It's really more about parents and parenting style with a pediatric population. However, having said that, parental control starts to fade after age 6 when the kids enter primary school, 6 years that is. Parental control is fairly complete up to that point, but it really starts going away rapidly afterwards. The control starts to shift before most parents really acknowledge, and it is ongoing from 6 to 12 years of age. And while most parents really are reticent to admit this, it's nearly complete by the teenage years. Kids are really making most of the choices for themselves. They have access to a lot of their choices, and parents, although parents like to think that they're having a bigger influence than they do, really mostly rests with the kids at this point. So it really is a process where it starts off, you're doing motivational interviewing with the family, and it's a slow transition to the kids taking over. You want to think about your 4 principles, whether or not you're doing this with parents or the children. You really still have to work through all 4 steps. When we think about our 4 principles again, remember it's engage, guide, evoke, and plan. The tools that you'll learn today are the following ones: open questions, reflective statements or reflections, the readiness ruler, and a technique called elicit, provide, elicit. One more thing before we get started. Every time a parent responds to something you say to them, they may be giving you back change talk or sustain talk. Change talk is something that comes back at you that says, hey, I might be willing to make a change with this behavior, while sustain talk indicates that they're not interested in changing. Let's take an example. If you were talking to someone about giving up smoking, and they said to you, I've tried giving up smoking before, it's impossible for me. That's a statement that sounds a lot like sustain talk, like I'm not interested in changing. However, because they said, I've tried stopping smoking in the past, I'm not doing it anymore, there may be an opening there because you could actually focus on something and said, so it sounds like you have tried this in the past. What have you tried? So change talk and sustain talk can be a little bit subjective, but in general, with every statement that comes back at you, you want to think about it. Is this a change statement or is it a sustain statement? Are they defending what they're currently doing, or are they saying to you, hey, I might be interested in a change? And sometimes you have to really think about and look into the statement to see if there's something that might give you some change talk to work with. It's kind of a subtle difference, but something you want to pay attention to as you're talking with patients and clients. So let's talk about this first skill, open questions. What are open questions? In general, we say that they can't be answered with a yes or no answer. I'd expand that a little bit and say they can't be answered with a single word answer. In the case of teens, who I work a lot with, that would fall under the term good or fine. So you want to have questions that really provoke a bigger response. They allow for fuller, richer discussions. They tend to be non judgmental because with a yes or no answer, like, are you having sex? There's clearly a desired answer. So open questions like, tell me about what sex means to you, is more of a open question. It's something that allows a richer discussion of what this might actually mean to a teen or someone else. It lets the person you're talking with think out loud, and it allows them to do most of the talking using their own words. It really sends an implicit signal to that this conversation is about them. It's not about you lecturing to them. There are helpful starters that will help you make more open questions. Things like tell me about, to what extent, what else, help me understand, how did you, and what, if any, can sometimes be helpful. I often say to learners that open questions are things that have to sound right coming out of your mouth. They have to make sense with the way you speak. A lot of times people will start off with the starter, tell me about, and then after a while it seems like they're starting every question that way. As you get better at it, you'll find some things that sound normal, things that don't sound quite as comfortable for you. You'll get better at it. But it's fine to use some starters at first and then learn to make them sound more conversational. You'll get there. One other thing we like to talk about with these starters is think about not starting questions with verbs. If you start a question with can you, will you, do you, there's automatically a presumption that it's going to have a yes or no response. Yes, I do. No, I don't. Yes, I will. No, I won't. But with open questions, it's better if you can start with interrogatives. If you remember from grammar, these are the how, when, where. Those are the kinds of questions that will get you a bigger, deeper response. I will tell you there's one word to be careful with, and that's why, which tends to be charged with judgment. So you can use it, but you have to be careful with how you state it. But in general, if you're using the W and H words, you're going to have more open questions, more of a tendency to ask open questions than if you start with a verb. Let's talk a little bit about reflective listening. This is really the central skill of motivational interviewing. If you learn reflective listening and you can practice reflective listening, you're really going to be on the road to performing motivational interviewing well. It lets the patient realize that you get it, and it evokes their internal motivation for behavior change. So what is a reflection? Well, it's like a mirror or a parrot. You just are telling people back what they've said, or maybe taking a stab at what they're feeling or the meaning behind what they're saying. We're going to give you some examples of this too. But it shows that you want to understand what the person is saying and lets you check that you're accurately understanding what the person has shared. I often say that it just opens the door to keep people talking. It promotes good conversation. People who know me know that I am an introvert at cocktail parties. So for me, reflective statements are a way for a natural introvert to keep a conversation going. I have to think about what was said to me, and then I can reflect something back. It's something that comes naturally to some people, but it requires you really to be attentive. If you're not paying attention and you're reflecting something back that's completely off base, people will know like, okay, this person just isn't listening to me. Now, having said that, if you reflect something and it's not exactly what they were thinking, but it's in the same line, and at least they can tell you were listening to what was said, they can give you a course correction. We often call practicing with reflective statements batting practice. Like if you reply and reflect something and accurately say what they told you, you're going to reinforce for the family or the client that you understand what they just said to you. If you miss, but you do it in a way that makes you inquisitive, they'll give you a course correction. It's almost like we say with batting practice, you learn more from a pitch you miss than a pitch that you connect with. But overall, reflections should really be conversational. Let's talk about this in a little more depth. There are several types of reflections: content, feeling, meaning, double-sided, and amplified are 5 common ones. Now, I put the names up not because you have to learn how to characterize these, but the names I find help me understand what I'm reflecting and give me different ideas on things that I might want to reflect with a patient. Let's take a simple statement and try some reflections with it. It's sunny outside. A content reflection could be basically saying exactly the same thing back, only in different words. Yep, the weather really is nice today. Let's take a stab at reflecting the feeling too. It's sunny outside. This spring weather really makes you happy. So I'm taking a stab that the reason the person said it's sunny outside is because the warm weather makes them happy. I could try reflecting the meaning. I could say, when they say it's sunny outside, knowing what I know about them, I could say something like, you must be really excited about getting your triathlon training going. A double-sided reflection would give you something like this to it's sunny outside. On one hand, I know it's great to see the sun, but on the other hand, I know how much you despise yard work. So you can see that even though you're acknowledging what they said, and you may or may not get it right, what it's sunny outside means to them, it'll still give you a chance to maybe get useful course correction or give you a chance to affirm that you understand them a bit. Let's take an amplified reflection and think about it for a moment. So amplified reflections, we also call them siding with the negative or coming alongside. You're not pushing back against what they said, and sometimes this is hard to do. You're coming alongside them so that you're using ambivalence to have them argue in favor of change, hopefully. I'll give you an example. You do have to be a little careful with these too because they can come across as snarky or confrontational if you don't do them the right way. So let's take a difficult statement like this. Your 16-year-old client who won't stop smoking marijuana says, "I am not quitting. It's safer than alcohol and it helps calm me down." Now, as a pediatrician, this conversation usually takes place and does take place, but usually takes place after a parent has said to me, "Dr. Bowling, would you please go in and tell my 16-year-old that he needs to stop smoking marijuana? It's going to make him not be able to get a job. It's going to ruin his schoolwork. He needs to stop smoking marijuana. Please tell him that." So my inclination when my patient says to me something like this is to, tell them what the parents say, like, you need to stop. It's going to do this. It's going to do that. It's going to be terrible. But an amplified reflection, knowing what we know about teens and the teen brain, is not going to respond well to a bunch of lecturing. So an amplified reflection might be more helpful. And an amplified reflection would go something like this. To a teen who says, "I'm not quitting. It's safer than alcohol and helps calm me down." It sounds like in some way marijuana is filling a very important need for you. So I'm not hitting it straight on, but I'm trying to understand why they're using marijuana. And in most cases, there's a bit of an opening that you can go with that marijuana helps calm them down, helps them to sleep, helps them to feel less anxious. So then knowing that, we can go in with a statement like, there might be other ways we could help you feel calmer or help you get better sleep. Would you be interested in that? So that's the way you would use an amplified reflection. You can see it can come across a little bit snarky if you said something like, "Well, I guess, it's fine for you that this is really the most important thing in your life to keep smoking marijuana." That does not get the same effect as saying something along the lines of, "It sounds like it's filling an important need for you." So it's a little bit of a nuance, but it can be a very helpful type of reflection where you're not trying to change behavior right away. You're trying to understand why the behavior exists in the first place. So let's talk about another tool that I find very useful, and it's called the readiness ruler. It really is a tool that I feel gets to the issue of ambivalence around behavior change. It addresses two things: importance and confidence. And oftentimes, when I see the readiness ruler used, I see providers ask questions like, how ready are you to do something? That doesn't mean a whole lot to me. I think you have to address both importance and confidence, and let's talk about what that means. So, importance are the personal values related to the behavior change. These answer the question, why should I change? Confidence is more about self efficacy. If I choose this behavior, can I really do it? How am I going to do it? And who's going to really be there to help me? Both of these things, the personal values and the self efficacy pieces, combine together to form readiness. So let's talk about this a little bit more. If I feel that someone is asking me about stopping smoking, and I have to first acknowledge that stopping smoking is important for my health. I have to accept the data that says that smoking causes cancer. I have to say, understand that there are agents in cigarettes that cause problems for my health. But that says nothing about my ability to actually do the change, to actually quit smoking. That's confidence. Conversely, I could be completely dedicated to stopping smoking, knowing how terrible it is, but still be nowhere near ready to change because I just have no clue how to do it. And I'm not aware that there are things that can help me, medications, support groups, etc., that could help me get through it. If you don't know what the hang up is, is it importance or confidence, you're not going to be very successful helping this patient change behavior. You need to know what the issue is that's holding them back, that's holding up their readiness. So you have to address both importance and confidence if you're going to figure out really, truly how ready someone is to affect behavior change. Now, this ruler that we're showing you now actually has a scale of 1 to 10, with greater than 7 being likely to change potentially. For those of you who remember, this sort of lines up with what's called the old trans-theoretical model, where patients were in pre-contemplation about changing behavior, contemplating behavior where they're going to do something within the next 6 months, preparation where they're going to change behavior in the next month, and action where they've just changed behavior. So it's one of those things that you can really, you have to look at them along the entire spectrum. And it's not a validated scale. It's something that just helps you it's a conversation continuer. It helps you continue the engagement and helps you talk with them in a way that you get some good information about what behavior change means to them. Now, I tend to prefer a readiness ruler that goes to 0 because I think it's possible for someone to have 0 confidence about changing behavior and also have 0 knowledge about what they need to do in order to change behavior. I think this looks a lot better if we talk about it in a case study. Now, you're going to have to bear with me because I'm going to play both the roles here, but let's do a case study. Ellie is a 5-year-old girl who is at the 99th percentile BMI for age and gender, and she's in with me for a well child check. On the 4-year well child check, she was at 94th percentile, and the parents were not concerned. The parents now state that they worry about all the juice that Ellie drinks, and they think that this might be causing her to gain weight faster than they want. Now, I know a lot of you are not pediatricians, but also are home visitors, and you can see the same sort of scenario playing out, that you see them on one visit where you're seeing a lot of juice consumption, and then you come back on a subsequent visit to have this story. So let's identify the behavior here first. Clearly what we're talking about is Ellie's mom changing the behavior of giving her so much juice to drink because it's obviously affecting her weight status and potentially her health. So you might ask the question of Ellie's mother. First off, on a scale of 0 to 10, we've identified stopping sweet drinks as a good behavior. But on a scale of 0 to 10, with 0 being this is not an important behavior for Ellie at all, and 10 being this is a very important behavior for Ellie to change, where is this for you with Ellie? Stopping drinking, that is. Stopping drinking sweet drinks, that is. And her mother might say something like, it's a 5. And you can say back to her, tell me why it's not higher. And they could say, well, it's important, but there are other things that I think are more important. It's more important for her to have a good self-image. It's more important for her to have friends at school. It's more important for her to be a happy kid. And then you could ask the question again, so why is it not a 3? And then the mother might say something along the lines of, well, it's not a 3. I know it's somewhat important. You've been telling me this, and now I see that it seems like it's affecting her weight. So actually maybe, it's not a 3 because it does have a certain importance. It's not all the way at the top, but it's important. Then you could say, okay, why? Let's talk about this a little bit differently. In terms of stopping drinking juice and sweet drinks, where are you on the confidence level? With 0 being, Dr. Bowling, there is no way I can be successful at this. It's just too hard. And 10 being, this is something that I could do very easily. I got this, no problem. And if Ellie's mom said again, well, it's a 4, and you could say to her, okay, so why is it not a 2? And she might say something along the lines of say like, well, it's not a 2 because she does kind of like water. So, I think that she has the potential to like water and maybe even some flavored water. Okay, and why is it not a 7? Well, Ellie really has a lot of tantrums. And I'm really worried that if I start doing any of this, she's going to start throwing tantrums. And I just don't have the energy with as busy as my life is right now and as stressful as my life is. I just can't deal with her throwing tantrums over it. So let's take a look and unpack a little bit what we just found out in this very, very short interaction. From the importance discussion, we know that it's rising to a level of importance for Ellie's mom. It's not off the radar screen. She's thinking about it. It's not at the top yet, but it is moving along, and probably further up than it was at the last visit. What did we learn from the self-efficacy or the confidence discussion? A lot there too. The first thing is she realizes that Ellie has some strengths. We almost had her arguing for behavior change. Like, well, maybe I could go with some water or even some flavored water as a treat because she really seems to like water, and that seems like a good solution. We've also identified some barriers for her. Her saying, like, well, I'm really worried about these tantrums and what that's going to do. So maybe we can equip her with some skills around tantrums if she's interested. So the bottom line is, with a few well-placed questions, you can get a wealth of information from a readiness ruler. But you got to ask the right questions in order to get there. It's a lot of fun. It's an easy way to incorporate motivational interviewing into your practice, and I think it's fun to try. You'll notice, again, don't forget to ask why not a lower number. That will get your patient or client arguing for their own behavior change, why it's important, what strategies they might use, in addition to asking the why not more. I think we're all good about trying to get them further up. Well, why can't you get to an 8 or 9? And those are important because they're identify barriers, but sometimes those are ways that will reinforce these negative concerns that the patients have. So don't forget to ask why not under. And I also ask you, really work on importance first. If you go to confidence first, who cares if they're really good at being able to do something? If they don't think it's important, it's not going to happen. So when you ask why not a higher number, you're going to elicit barriers. When you ask why not lower, you're going to have them arguing their strengths. And even maybe identifying their strengths. And if you do confidence first, you might miss the boat. Let's talk about what is arguably my favorite and most used motivational interviewing tool. This is one I love, and this is one that as providers and healthcare workers and home visitors, I think you'll find it's really helpful. It's a nice, easy way and really insightful way to get a lot of information from families. So what is elicit, provide elicit? It's really a synthesis of a bunch of different motivational interviewing skills. You can use this in conjunction with reflective statements and open questions, and that's really what it's made up of. Also, with a couple of well placed other sorts of questions. You're trying to get a limited piece of material transferred, and you're trying to give some things that could potentially help behavior change in very bite sized pieces, delivered in the spirit of motivational interviewing. So it's important to remember elicit, provide, elicit is not advice giving, it's information giving. The amount of advice, as in not very much, is critical. Frequent mini repeats are preferable to big, long soliloquies. Think about these being EPE sandwiches, not foot-long submarines. So you're providing a piece of information that is sandwiched between two eliciting statements. Now, don't get too panicked. We're going to show you how to do this. So elicit is something along the lines, maybe with an open question, what are your thoughts on behavior change X? And then the provide piece is, may I share some ideas with you on this? And then the third piece of it is circling back around and saying, what do you think about that? Let me take an example of giving a flu shot to a patient. This is a 6-month-old. This is an actual case, 6-month-old in our office. And I happened to notice that they usually did not get flu shots for their older child, their 3-year-old. And they were not planning on giving their 6-month-old the flu shot. So I started off an elicit, provide, elicit cycle with the family by saying, so I've noticed that you guys have typically not gotten the flu shot for the kids. What are your thoughts on that? So I'm trying to give an open question so it's less judgmental, as they know that I like the flu shot. So what I got back was the family saying, I've really been noticed that we never really get the flu ourselves. And I've also been concerned about certain things. I found out, the mom said that she found out that she has what's called MTHFR deficiency, which means that she might have altered metabolism of certain medications. And she said, I've heard that people with this genetic trait have a higher rate of immunization reactions. So I then gave a provide segment. I said, may I share some ideas with you on what we know about that genetic variation and vaccine reactions? And she said, yes. If she said no, I would have stopped right there. But she said yes, as almost all patients will do. And then I was able to tell her, what we know about this is that it has no relationship with that gene, that having that gene has absolutely zero impact on any immunizations. And there's never been any link, especially with the flu shot, with people who have that genetic variation. And then I circled back around and said, so what are your thoughts on what I just said? And what she said to me was, she said, I'm glad to hear that. I've been worried about that. We believe in all the other vaccines, and we really are scared of these illnesses. And we know that flu can be a bit of a problem. So I appreciate that. If you could I send you information when I see this stuff and have you take a look at it for me? Now, while we didn't get the flu shot that visit, it was progress in the right direction. In that same visit, the father also then asked and said, I never think of the flu as being very much of a problem, that when people get the flu, they don't seem to really get all that sick. And I've never really gotten the flu. To which I then had another opportunity to say, can I share some thoughts with you on that one? And he said yes. And then I was able to talk a little bit about how flu year to year will change in severity, and that people who get the flu shot, even though they might still get the flu, they wind up getting a milder case. And then he went in asking for his opinion on that. He said, well, that was really interesting. I didn't know that either. So I think, what you do with these EPE cycles is you want to repeat them frequently, and you're not trying to give all the information, in my case, all the information about flu in one fell swoop. You're addressing each individual one, and you're asking for permission repeatedly. It's really eye-opening when you ask for permission. There's something really magical about it. And I have a lot of providers who are very resistant to doing that. They say, you know what? They're here in my office or I'm visiting them wherever they are. They've picked me as someone to help them with. They're here clearly because they want information. I'm going to go ahead and give it to them. When really what asking permission does, it lets them know that they still have control over their own health. It's a really powerful exercise and it's really liberating because then you really understand that they're paying attention to you as well. So, what are the essential pieces of elicit, provide, elicit? Asking for permission to offer information is critical. And again, it's information much more than it is advice. You're giving a very small piece of information and you're not forgetting to ask for a response. A lot of times that last elicit gets forgotten, but you'll often go through a sequence of elicit, provide, elicit cycles. Don't forget the second elicit. Let's do another example with it because I think it's important to understand this one and it takes a little while to get the hang of it. But it's great too because you can hear different reflections and open questions in it. So our second case study is about Davis, who is a very active 4-year-old who his mother reports is very rambunctious. His mother states that he is sometimes hard to settle and will hit and bite others at times when he gets very frustrated. He has already been asked to leave 3 daycare facilities. His mother states that she has resorted to spanking him when he gets in trouble. She says she is getting frustrated and is trying everything not to lose her current daycare arrangement. She really doesn't know what's going to happen if that occurs. With this, you notice what? Okay, so she is spanking him for aggressive behavior. Again, kind of confusing for a 4-year-old. They'll often take away the message from that it's okay for bigger kids to hit smaller kids. And really what you're trying to correct is aggressive behavior. So it's kind of hard, kind of confusing to kids to answer aggression with aggression and say, don't be aggressive, and I'm going to be aggressive to show you how not to be aggressive. So what might be a better solution? Maybe isolation, maybe giving some tips around timeouts. So in your mind, you're going through it like, okay, yeah, this is what we need to we need to address. We need to get her in a less aggressive stance with him. We need to get her some other options besides corporal punishment because clearly that's going to escalate the situation potentially. So you want to give her some other ideas about how to do non-aggressive behavior modification. She says something along the lines that I'm really scared that I'm going to lose this last daycare facility and I just can't do it. And you start off with saying to them, have you thought about other possible ways of disciplining him? Or what other possible ways would be a better question since it's an open one. What other ways have you thought about? And the mom says, I've heard about some other strategies like timeout and some other stuff, but I just don't think these are going to work because I could never see him sitting in timeout. Then your question could be something along the lines of, may I give you some thoughts on behavior change and doing timeouts in this age child? And if she says yes, you then proceed to give her an explanation that might go something like this. Well, sometimes what we do with timeouts with kids who won't stay in position in the chair, sometimes you can actually make sort of a penalty box, like make a room in the house. If you have a room in the house that could serve as the place where Davis goes, where he just cools off for a little while after he's been biting or been aggressive. What are your thoughts on that? And she might say something along the lines like, yeah, that's great, but I just don't know how long I would do that. To which you could say, can I give you some thoughts on that piece of it as well? And if she says yes, then you say, well, generally what we do with 4-year-olds is we think it should be 1 minute for every year of age. So for Davis, that would be a 4-minute timeout. What are your thoughts on a 4-minute timeout? And then she could say, well, that sounds like a possibility, or that sounds too long. And then you can move on with it from there. But basically what you're trying to do is figure out what's going on with the child, what her strategies have been, and then give her the opportunity to get some information from you on what might be more productive. So this is a process that actually can take a little while to get the hang of, but you get there if you practice it. Practice is so critical when it comes to motivational interviewing. It's the kind of thing that in the abstract, you can look at it, you can think about it, but until you actually try it, it's really difficult. So I would suggest a couple things that you might want to try in your practice. In your families who have children with nutrition or activity challenges who you are visiting, you might use and document the use of an illicit provide illicit cycle to address readiness to adopt a healthier behavior. If you see them going to bed with a bottle, if you see them practicing unsafe sleep techniques, those might be opportunities to try illicit provide illicit cycles. Give it a whirl. Another thing you might do is if you have a family where the behavior change is agreed upon, something where they know they want to try something, you might try using the readiness ruler. And remember to assess both importance and confidence. You want to pay attention to the changes from visit to visit and see what happens on subsequent visits. But I would encourage you to try these things in your practice. There are also some other great resources that are going to be listed on the Ohio AAP website that you can learn some apps that will help you practice this. There's one on the iTunes and an Android where you can actually practice motivational interviewing skills with it. So there's a lot of good opportunities out there. So practice makes perfect though. And you'll learn some of the little challenges with it the more you try it out. So in conclusion, practice makes perfect. Get out there and try things. Try motivational interviewing. You're not going to be comfortable with it overnight, and be okay with that. I always say to folks, remember that first visit that you made, or the first patient you contacted, or the first person you interviewed. You were very nervous. You were very awkward. Same thing goes here. Give yourself time. Be easy on yourself. Give yourself time to learn it. You're going to learn phrases that sound normal for you. You're going to learn things that you have to avoid. They just don't sound right. It really represents a change to the language we use. And it's about language. It's about listening. It's about paying attention to when people say certain things that like, hey, this might be a time to bring about a behavior change. They just gave me a clue that they now have an opportunity to do something. And make sure you have fun with it. Those of us who do motivational interviewing view it as a sort of a liberating way to talk about difficult subjects with patients. There are hard conversations that we all encounter day in and day out, and MI can be one way to help you deal with some of those more difficult conversations. So have fun, keep practicing, and if you have any questions, feel free to reach out to us through the Ohio chapter of the American Academy of Pediatrics. This concludes today's presentation.
Hi, my name is Amrik Singh Khalsa. I am a physician, clinical scientist, an assistant professor of pediatrics at Nationwide Children's Hospital. I'm dual boarded in internal medicine and pediatrics, and my research focus is largely on the prevention of obesity in early childhood. Some of my interests include decreasing disparities of obesity in early childhood and finding novel and innovative ways to prevent obesity in this time period. Welcome everybody. Today I'm going to be talking about feeding young children, working with parents to promote responsive feeding. I am an assistant professor of pediatrics at the Center for Innovations in Pediatric Practice at Nationwide Children's Hospital and The Ohio State University. Thanks for joining us today. I have no competing financial interest, but some of the work presented in this presentation was previously supported by an institutionally funded T32 grant awarded to the Cincinnati Children's Hospital, Division of General Pediatrics. So the objectives of this talk are as follows. We will first talk about and define feeding styles and how this relates to parenting styles. We will then go over the major categories for feeding styles, including responsive feeding and non-responsive feeding. Next, we will further discuss how feeding styles can impact outcomes, including the future risk for obesity. And finally, we will discuss how to promote responsive feeding styles in parents of very young children, that is, from birth to the age of 2 years. So just some background on feeding styles. Healthy feeding behaviors are needed for healthy growth as well as healthy social, emotional, and cognitive development. Feeding styles are the attitudes and behaviors parents use to achieve their feeding goals. Feeding styles are in a way an extension of parenting styles, that is, how parents raise and promote development of their children. However, I want to note that feeding styles and parenting styles are distinct and unique. While many aspects of parenting styles and feeding styles overlap, they are different entities, and so it is important to ask, why are feeding styles so important? Well, feeding styles have been linked to the following: healthy weight trajectories, healthy social, emotional, and cognitive development, and they're thought to be a key component of obesity prevention in early childhood. Now you may ask, obesity prevention this early in life? How is that possible? Well, let's take a pause and let's talk about obesity and the rates of obesity just for a moment. As you may or may not know, early childhood obesity is defined as a child with a BMI greater than the 95th percentile by the age of 5 years. 41 million children under the age of 5 are considered overweight or obese worldwide. And although there's no consensus on the definition of obesity in children under the age of 2, about 8.1% of children living in the U.S. have a weight for length ratio that is greater than the 97th percentile using WHO charts. Children who are obese at age 5 are 5 times more likely to be obese when 12 years or older, and infants with a BMI greater than the 85th percentile at 6 months have a threefold increase of being obese by the age of 6. A recently published article in the New England Journal of Medicine displays this well, showing us that while 8% may be obese at the age of 2, the prevalence can quickly become 60% by the age of 35 years, as will be shown in this graph momentarily. And as we know, obese children have higher rates and earlier onsets of comorbidities compared to their healthy weight counterparts. Here again is, as displayed on the chart, the rate of obesity can increase exponentially during a person's lifetime. Additionally, socio-demographic disparities in obesity are noted by age 2 years of age. What's important to note is that the first 1,000 days is considered the critical window, that is, from conception to age 2 years. This is the time during which infants and toddlers learn how to accept healthy foods and establish long-term dietary patterns. It can also be during this time where we prevent the onset of chronic diseases, including obesity. Caregivers play a key role in understanding and appropriately responding to infant and toddler cues. And this can be manifested through parenting styles and feeding styles. I want to take a moment to define and expand on feeding styles. As noted here, there are several definitions, and they include the following. Feeding styles can be defined as the parental attitudes regarding feeding, the behaviors parents use to achieve their feeding goals, and or the emotional context of the feeding interaction. There are 5 types of feeding styles in infancy and early toddler period, and include restrictive, pressuring, responsive, laissez-faire, and indulgent feeding styles. In general, these are believed to be on a spectrum based on the level of parent control there is, with restrictive and pressuring being on one end, and laissez-faire and indulgent being on the other. In between is responsive feeding, where parents monitor the quality of food provided and are attentive to the hunger cues. This is considered an ideal feeding style. To get everybody on the same page, I want to make it easier by providing a few examples. Of note, these are based on sample items from a survey that measures feeding styles in infants. So let's suppose we have Mom and Johnny, an infant who is 9 months old. If Mom predominantly restricts the food she provides, she will carefully control how much Johnny eats. If Mom predominantly pressures, she will encourage Johnny to finish his food even if he seems full. If Mom is predominantly laissez-faire, she allows Johnny to eat while watching TV. If Mom predominantly is indulgent, she allows Johnny to eat desserts or sweets to make sure he eats enough. Finally, we have responsive feeding style. Of note, here Johnny is in control, so Johnny decides how much to eat and when he is full. Mom provides some structure including types of food, but does not exhibit too much control. I recognize that some of these icons are simplistic, but I had them here to serve as a quick visual reminder to remind us of the general idea. Expanding on responsive feeding is a component of responsive parenting that involves the reciprocity between child and caregiver during feeding. There are a few key steps in this interaction. Of note, before we get there, responsive parenting fosters the development of self-regulation and promotes cognitive, social, and emotional development. Now, coming back to responsive feeding, key steps in responsive feeding include promoting a child's attentiveness and interest in feeding, promoting the child to communicate needs to the caregiver with distinct and meaningful signals, the parent paying attention to the child's internal cues of hunger and satiety, and the caregiver recognizing cues and responding promptly in an emotionally supportive and developmentally appropriate manner. Finally, this leads to a predictable response for the child. So the child understands that the parent will come provide food after a certain set of cues or after certain behaviors. And this, in totality, can lead to successful progression to independent feeding. Now, let's talk about how responsive feeding or feeding styles in general can relate to outcomes later in life. Non-responsive feeding styles have been shown in the literature to lead to the following. Caregivers taking too much control and either being too pressuring or restricting the food in which they provide their child can lead to future risk of abnormal eating practices, including things like anorexia, bulimia, and emotional eating. This is thought to be through the loss of internal hunger and satiety regulatory cues. This can also affect child autonomy and independence. When the child is in too much control of the situation, as in laissez-faire and indulgent, this can lead to indulgent eating practices. And both of these non-responsive feeding styles are associated with the future risk of obesity. On the other hand, responsive feeding is one that promotes positive outcomes. Literature shows that responsive feeding leads to self-regulation of food intake, awareness of internal hunger and satiety cues, decreased or slower weight gain, and along with the future reduced risk of obesity, and furthermore improved sleep. Now you may ask, how do we promote responsive parenting or feeding in early childhood? We want to help parents understand that responsive feeding is important to support their child's growth and emotional and social development. Responsive feeding is shaped by how and what is fed to the infant. Responsive feeding also recognizes their child's hunger and satiety cues. And it's important to note that these hunger and satiety cues evolve over time and are specific to certain ages. Additionally, parents have to recognize that there are early, active, and late cues. For example, a 3-month-old infant who's showing early signs of hunger may be suckling, whereas active cues may be turning their head to their breast or rooting, and a late cue of hunger is crying. Parents need to recognize that responding to early and active cues should be done in a supportive and warm way. For going back to the example from the 3-month-old, if they see the 3-month-old suckling or starting to turn their head to the breast, you want to start talking to the child to make them aware that food is coming. For example, "I'm coming, Johnny. I'll be right there. I know you're hungry." This allows the child to recognize that the parent is coming with the food very shortly. Additionally, we want to allow parents to understand that responding to cues should be done consistently and in a similar manner. So again, the child recognizes that their set behaviors and patterns lead to certain actions. And finally, we want to allow parents to understand that parents should provide nutritious and healthy foods throughout this entire process. Now, much of what we've presented here is reported in the Healthy Eating Research document as noted in the bottom and will be shown at the end of the slides as well. And this document shows a lot of recommendations of what to feed and how to feed children in the first 1,000 days of life. Again, that is from birth or even preconception to the age of 2 years. And here I'm going to go over some of the key time points and ways on how we can promote responsive feeding in these different time points. So for example, in the prenatal or immediately postnatal period, It's important for the mother or the parent to recognize that they need to eat nutritious and a variety of foods, with plenty of fruits and vegetables during pregnancy and while breastfeeding. What may or may not be known is that much research has been shown that during pregnancy and while breastfeeding, many of these foods or compounds of these foods are noted in the breast milk or even in the amniotic fluid, and so the child is exposed to these even earlier than what may be thought of initially. In the first 6 months of life, we want to promote exclusive breastfeeding whenever possible. Additionally, we want to delay the introduction of solid foods and beverages until 4 to 6 months of age. And if we're providing formula, we want to provide amounts consistent with the age. That is, roughly 2 to 3 ounces for 2 months old versus 4 to 6 ounces for 5 months old. Now, it is important to note that even though there are general guidelines on how much a child should be fed, again, these will largely be based on what the child's feeding cues are, and we want to be able to follow the hunger and satiety cues of a child, and not just strictly by the number of ounces per the age. In the next 6 months, we want to be able to provide gradual introduction of solid food when the child is developmentally ready, that is, when they're munching or chewing, and they're sitting up unsupported. You want to start with vegetables or fruits and offer 1 to 2 teaspoons of pureed or mashed foods, increased slowly. And the idea is, we want to continue to monitor the child's hunger and satiety cues. We want to continue to breastfeed if breastfeeding is occurring. And if not, we want to be able to provide formula in amounts that are consistent with their hunger and satiety cues and for their age. Additionally, in the 6 to 12 month period, it is important to avoid juices and sugar-sweetened beverages, as it is way too early for children to be exposed to this. Children naturally have certain taste buds, including a sweet taste bud, and they will always enjoy sugar-sweetened beverages as a way of soothing. But this is to be avoided during this age period. You want to be able to transition infants from bottles to cup if possible, and promote the use of spoons around 8 to 9 months. Finally, you want to allow infants to be able to explore solid foods with their hands. This allows them to use all of their senses. And while this may make the mealtime a little bit messy, this allows them to explore the foods that they are going to eat later on. It also allows them to develop their other motor and developmental skills, including fine and even gross motor skills, along with some of their other abilities. Between the ages of 1 and 2 years, you want to continue providing a variety of foods, including, and most importantly, fruits and vegetables. You want to recognize that toddlers eat 5 to 6 times a day, which includes healthy snacks. Water and milk are the only fluids that are needed. Again, we want to avoid juices and sugar-sweetened beverages. And finally, you don't want to put toddlers to sleep with a bottle or a sippy cup. This will help avoid dental caries and oral health problems, and also will prevent feeding to soothe. As mentioned, much of the information and content of these slides are in the Feeding Guidelines for Infants and Young Toddlers, a Responsive Parenting Approach, guidelines published by the Healthy Eating Research in 2017. These are evidence-based guidelines to promote healthy nutrition and lifestyles. They have concrete recommendations, including the ones that I provided, on what and how to feed infants. Additionally, you can also look at the Healthy Eating Research division of the Robert Wood Johnson Foundation, which has evidence-based guidelines and resources on how to prevent childhood obesity. The link is shown here and will provide it in your material. I want to acknowledge my mentors at both Nationwide Children's and Cincinnati Children's Hospital, along with the funding sources. I want to thank the Ohio AAP for providing this opportunity. And if you have any further questions, please don't hesitate to contact me at the email provided here. Thank you so much.
Well, welcome everybody to How to Help Build Daily Routines, a simple way to help parents in their everyday lives. One of the things that's most striking about this particular topic is that a structured day that has a very predictable course is very important for lowering stress among children, but it also lowers stress among parents. One of the real challenges we have anymore is time, and in this particular tool. When you lay out a structured day that unfolds in a predictable way, both parents and children recapture some of their time, their expectations are set, and it really does take stress down. So this is an important strategy for new parents to learn. Infants in the first months of life are growing and learning so fast that they usually eat 8 to 10 times per day and sleep for 16 hours or more. This is normal. But newborns are also at risk during sleep from suffocating. Deaths occurring during sleep are called sudden infant death syndrome, or SIDS. It used to be all too common among newborns, but researchers began to show how to prevent SIDS by changing the baby's sleep environment. These are the steps to keeping a baby safe during sleep. They can sleep in the room with you, but not in the bed with you. Use a firm, not fluffy sleep surface. The bed should be empty and free of toys, bumpers, pillows, blankets. A simple sleep sack will keep them warm and comfortable. Breastfeed, but avoid smoking, alcohol, and drugs that may be transmitted to the baby. And then use a pacifier to soothe the baby if they need it. These things are really an important component of keeping the newborn baby safe during sleep time. It's not just newborns. We all need to get enough quality sleep to be at our best. In particular, young children need the most sleep because of their high activity, rapid growth, and constant learning. Enough sleep at night helps them be active and happy during the day. Insufficient sleep and secondary daytime sleepiness impacts how a child's brain works. More behavioral problems, more impulsiveness, irritability, and aggression. All of these things make up the child's daily life. And also, poor sleep has been linked to overeating and weight gain in both children and adults. It might surprise you to see how much time a child needs every night. So to build a child's daily routine, advise parents to start by making sure that there's enough time set aside for their child to get a full night's sleep. This means setting a regular bedtime in the evening. Just having a scheduled bedtime in the evening helps a child to develop a habit of getting ready for sleep. Parents can help their child ease into sleep by having a quiet, slow-down period in the 30 minutes before bedtime. It's important to cut down on stimulation during this time and switch over to getting ready for sleep. A consistent bedtime routine results in earlier bedtimes, shorter time to get to sleep, fewer nighttime wakenings, and longer sleep duration. Parents report fewer sleep struggles and better daytime behaviors. And the benefits were seen just a few nights after starting the new routine. Using the 4B routine also helps the child pick up dental care and reading habits at the end of the day. All of these outcomes help lower stress, both for the child and for the caregivers. One of the most positive benefits of using the bath, brush, books, and bed routine before sleep time is to create a time when the parent and the child can snuggle and read together. More than anything, this habit helps lower stress, both for the child and for the parent at the end of the day. Kids like having a structured day. It gives them a sense of what to expect. Parents also prefer the benefits of having a routine because time doesn't slip away from them so easily. Running out of time to read together with their child is a common complaint among busy parents. Starting a solid pre-sleep routine carves out time for reading. The act of reading together makes the family slow down and lose some of that daytime stress. Darkness makes the body flip over into sleep mode. Likewise, sun and light exposure in the morning encourage waking up. Provide natural light and noise levels for all rest periods. Daytime naps are meant to be light and usually brief, while nighttime sleeps are heavier, more intense, and require darkness and quiet. For a child, playtimes are when they learn many new people skills, such as how to play with others, sharing, following the rules and being fair, how to communicate and solve problems, and how to work together with others in a group. These are skills that will help them all through their life. Keep blocks of time open during the day for kids to play freely. Play is also a time when children develop muscle strength, eye-hand coordination, creativity, and the power of shared make-believe with others. Different environments teach different lessons, so parents and schools need to make sure that kids have as much outdoor and indoor opportunities to play together as possible. In the first years of life, kids begin to build up their play skills. These basic motor skills will get more and more complex as the child practices them. There are two kinds. One is moving their body in space, and the other is moving objects such as a ball using their hands or a tool such as a bat. Children who don't get chances to build up and practice these skills begin to feel uncoordinated. They tend to drop out of active games with other kids as they get older, making them feel more isolated. Parents and preschools have a real opportunity in encouraging these kind of games among young children in their most formative years. Meal times and snack times also are routines that help offer a child good structure during the day. 3 well-planned meals with 1 or 2 smaller snacks will keep providing the energy that the child needs to stay active and alert. The quality of the meals and the snacks are critical. Too many American children have plenty of calories, but a low-quality diet overall. So every meal and snack should be an ever-changing mix selected from the 5 basic food groups to make sure that the child gets as many nutrients as possible during the day. Parents can make sure that there is enough room for all these nutrients by keeping sweets and fatty foods to a minimum. Routines matter. The whole family benefits. Start with a set bedtime. Build up the pre-sleep routine of bath, brush, books, and bed. Reading should be a treasured time for the child and the parent. Make sure that the room helps the child sleep, dark and quiet. And during the daytime, keep to a structure that lets the child know what to expect and when to expect it. Thank you.
We sincerely appreciate you spending your time with the Ohio AAP to learn more about these important topics impacting children's nutrition and play. You can access the Parenting at Mealtime and Playtime resources on our Ohio AAP website. Thank you to our presenters for all they do for the Parenting at Mealtime and Playtime program and for Ohio's children. If you have any questions for Ohio AAP, please don't hesitate to call us at 614-846-6258. A big thank you to you for your ongoing efforts to assist Ohio's families.